So, and this is just to prove that the left upper pulmonary vein Doppler pattern was very, very blunted from this thrombus. And this patient went back into DOAC, and after 3 months, this is from this, you can see that only a little bit of hypoattenuation thickening was seen on the follow-up. He came off DOAC, and then we decided to repeat the study 6 months later because of the other finding, and it had completely resolved. I have a friend in Texas. He's a cardiothoracic radiologist, and he calls me and says, Alex, can you take a look at these images? And we zoom and I take a look at this plug device that one of his interventionals, who I know as well, had placed. So for the cardiologists in the audience that are frequently doing these procedures, what do you think happened here? Intraprocedurally, what do you think happened? So I'm not going to make you guess what I'm thinking, but most of us, when we do TEs to find the left atrial appendage, we go to the level of the mitral valve, we antiflex at 45, and that's something that the fellows in the audience that work with me tell you, do not do. Try to go to the aortic valve, turn at 0, and start investigating horizontally before you go down. Look in multiple places, and then go down and do everything else, but look in many different places. I can tell you this was probably a 45 and 125. They've never captured this until superior lobe, and they felt this was the appendage here. And this is a high risk for embolization. You can see that this plug device is partially in the left atrium. You can see it here, and you can also see it here. And you can actually tell the angle that how much of the circumference is out. This is one of my cases. There have been 3 cases of this complication. Again, this is something to take with a lot of humility. We're touching human lives, and we have to realize that the procedures we do carry tremendous risk, and sometimes there are problems associated. This is a case of pulmonary artery injury with a double seal device. The tines eroded through the left atrial appendage wall into the pulmonary artery. You can see the tines engaging the wall. And here you can see it on the CT. So there are, of the 3 or 4 cases that have been published and the patients were alive, the other many patients on autopsy were found to have, were in tamponade, and the reason was found to have a PA injury. The patients that actually made it to surgery, it was found that it was with a deeper implantation. We didn't have a lot of depth here. Device oversizing. This device is appropriately sized, but more importantly, the relationship of the pulmonary artery to the left atrial appendage. So whenever you're reading this, look at the adjacent structures. See how close your PA is to your left atrial appendage, and also the circumflex. I can tell you we've had at least 2 cases of ST elevation upon deployment. And if you're not looking at the screens when you're deploying, you may miss that, and patients may come out actually with a STEMI. So now this is another study. You can see on the same patient, you can see now this is the pulmonary artery, and now we're doing a gated study, but triggering not for left-sided structures, but for right-sided structures. Just as I finished, remember that you can do evaluation of atria clips. I have had at least 2-3 atria clips with thrombi, particularly in patients that had mechanical valves. And sometimes you have lobes that are not completely excluded. And I think the future, what holds is, this is something Dr. Winkler and I have spoken briefly, what the future holds is a combination of multiple modalities giving us an answer for what the optimal therapy is. And what you can see here is that after implantation, there was a change in hemodynamics and electric currents and contractility in the left atrium. And we knew that the left atrial appendage is responsible for certain output. So basically, that's something of more to come. And with that, I'm going to finish showing you some of the cases of how flow and 4D flow, these are my patients. This is normal diastology. You see linear flow in, out. This is a patient with depressed ejection fraction. This is a patient after TAVR, and this is actually a patient with thrombus. So I think with that, I thank you all. And